Thank you for joining me, Mukesh Kapila, to breathe life into fading causes. We talk today on global health, but what is it? Well, everyone has an interest in their own health. Some are even pathologically obsessed. In fact, hypochondria is a good business, but we have evolved not just to be selfishly concerned with our own health, but to also care with the health of others. And as you know, the COVID-19 pandemic showed humanity at its best and also at worst. Has health become another front in our age of unending competitions and conflicts? And yet to counter that, on our TV screens, we see dazing humanitarian health heroism in wars and disasters all around the world. That is the context of global health. To dissect further, I have a very special guest, a political scientist by background. He grew up in Germany and India, served in distinguished roles in the World Health Organization and elsewhere in era-defining policymaking, and worked as a researcher and educator in prestigious think tanks and universities. She has published countless books and papers and won numerous plaudits and awards. Professor Ilona Kickbusch, welcome to Fading Causes.
Well, Mukesh, thank you very, very much. I'm really looking forward to this conversation in a way that the audience can relate, because as you indicated, it's an incredibly complex interaction of forces, particularly now.
Great. Ilona, now you've been called the Angela Merkel of global health, and I mean that as a compliment. And reading her memoir and studying your own copious writing, I see the similarities, including straddling the Berlin Wall era. But I also read, amusingly, that you originally wanted to be a librarian. But what shaped Ilona and the way your life has turned out?
Well, Mukesh, what shaped me most is having my childhood and early teenage years in India. So from the very start, I grew up speaking two languages. I got to know another culture, the Indian culture. I even spoke a little Tamil, and that has influenced my international dimension. And it was easier for me than for others growing up then in Germany, going to university, because I spoke English and I had access to all the literature. I was always in love with literature, and at the time when I was young, one did recommend that one went to university to become a professor of literature. I was a girl, and so they recommended I become a librarian. I did my degree as a public librarian. And this fell into the time of the students' movement, and we were concerned that public librarians are actually quite arrogant in terms of what people should be reading and what they should find in a public library. So we started asking the big question, how public is the library and what voice do people have? So I fell into the students' movement and then women's movement. And then at university, we had a professor who was one of the first to understand the health system as a political system, not just a system of care, but a system to be financed, organized, that was dependent on politics and policy. I was then researching the impact of social support on health, analyzing the self-help movement, and came in contact with WHO. And before I knew it, I was one of the youngest professionals in the WHO regional office, the only social scientist. And from then on, I worked on first, as we called it, international health, and afterwards global health. I think this being grounded first internationally and not only having a Western perspective, and the other side having a social movement perspective has really stayed with me throughout my work.
Well, that makes things clear. I have to say, I was teasing you about being a librarian, but I can see now that as a curator of knowledge and as a producer of knowledge, those skills have not been irrelevant in your subsequent career. Now, coming to WHO at the very beginning, 1948 definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It sounds great, but this has been criticized as hopelessly utopian, including the implication of visualizing all the world's problems through the health lens. How do you interpret this 75-year-old utopian definition today? And what does health mean for people amidst their daily realities in our age? Should the original definition be updated, perhaps?
Well, many people have tried, particularly countries from the global south wanted to add the spiritual dimension. Now, I think one must look at different parts of the definition. It's absolutely critical to have physical, mental, and social well being. And the social well being is still not seen as seriously as the physical. We are just rediscovering how important the mental dimension is. And we took that up in the Ottawa Charter for Health Promotion, which has its 40th anniversary this year. We said health is a resource and process. I think the weakness in the definition is that it speaks about a state as if it were something compact. Whereas health, everything we know about our interaction with our bodies, with our mind, the interaction with our social environment and everything else, that is incredibly dynamic and is both short and long term.
It's interesting, Ilona, you mentioned the spiritual dimension, and I've just started Tai Chi in an attempt to improve my physical fitness. And there, the spiritual side comes in very important. And, we've seen the growth of yoga and other such movements. So maybe the spiritual side is not that out of vision when it comes to defining what it means for ordinary people to be in a state of good health.
Absolutely. And if I think of the health promotion movement, we built that very much on the research of Anton Antonovsky. He says most important for health, being grounded in a way you could call it spiritual, he says, is having a sense of purpose and meaning. And if you think of it from a sociological perspective, in present society, we have this feeling that there is a loss of meaning, loss of sense of purpose, and that obviously interacts with their physical, mental, and social health. So as we look at issues around aging, connectivity, I'm really fascinated with recent developments around brain health. I do think we have a challenge there that many of the Asian civilizations have a deeper understanding of this spiritual dimension, and that is something in this digital age we have to think very seriously about also as health professionals.
Fascinating. Coming to another modern dimension, there is much polemic around health as a human right, but we're now in an area of great contention, even toxicity around human rights. So my question is whether tying up health with human rights so aggressively, as many activists do nowadays, is it necessary or unnecessary, helpful or unhelpful?
Well, to put it bluntly, health is a human right. We are humans, and because our health is not just dependent on ourselves and on our genetics, but is dependent on the environment in which we live and work and play. And that environment is shaped by others. It's shaped by political decisions and many other things. So we link health to rights one has within a society, because it is actually the responsibility of those in political power to ensure that citizens have access to health. And that doesn't only mean health services, it means access to safe water, housing. It means access to many of those conditions of life. If you look into the brain now, you have no more warmth, you have no more electricity. So yes, health is a human right, and there is an integrity about being human. And of course, it has expanded. The first expansion was around women's health. Hey, we should have the same rights as men. And part of that right is the right to be healthy. And the many special issues around human rights and women's bodies that are important. And then think of the AIDS movement, when human rights became important in another way, that people who had a different type of sexuality said, we have a right to life, we have a right to medicines, and they fought for it. Where things are difficult, and I speak now as a political scientist, in Anglo-Saxon societies, and particularly in the United States, is very much focused on the individual, whereas the European tradition of rights is grounded in social rights and in solidarity. And there is a clash between this individual right and social rights, but there are many countries who don't give people their rights, and we need to fight for it. And as always, out of social movements, you get an extreme radicalism at one stage, but radicalism usually leads to some kind of reform. And we've seen that through women's movements, some of which were very radical, but it did lead to different types of cancer care, access to safe abortions, and other things.
Well, Ilona, you've spent a lifetime in this business and have a bird's eye view of world health. How healthy are we collectively as humanity compared to, say, 40 years ago? And what have been the 3 or 4 most critical advancements that brought progress?
Well, if we look back, the first big steps were changing the environment for public health, making sure people had safe water. We understood why we have cholera epidemics. So the greatest breakthroughs in health have been social and political. We created better housing. We created rules for how many hours people should work. We created old age security. So many of these environmental issues led to improved health. And we speak about childhood vaccination. That has led to significant improvement, but actually child mortality was going down even before vaccines because water was safer, there was education, women had better livelihoods. So we must always see that together. We have a tendency to look at, big medical revolutions. And in COVID, we were fascinated. We got a vaccine so quickly. But everything else that has to be shaped around that is absolutely critical. Of course, we were able to eradicate smallpox. We were able to reduce polio, control measles. And what do we see now? Because of a strange debate in the United States, measles cases in children are going up astronomically. So yes, we've had enormous medical breakthroughs that allowed us to live longer, but what really has made the difference is that our lives have gotten better. And that's the situation between the global north and the global south now, that for many people in the global south, life has not yet got better. And therefore, they are subject to enormous amounts of infectious disease. There has not been political action to counteract neglected tropical diseases. There is not enough access to safe maternal and child health, though there has been progress here. So we've moved forward, but if you look at the non-communicable diseases, and the majority of people around the world now die of non-communicable diseases, we have not taken the political action we could around tobacco, alcohol, and many other things that destroy people's health. And you've mentioned earlier, Mukesh, the environmental challenges, air pollution, societies full of cars, and all of those things have stopped us from having the health we actually could have. And now we see that the digital revolution is influencing negatively the mental health of our children. And again, we have not yet found the political response.
Well, I think the important point to make is that we may have made progress, but we can't take unending progress for granted because the world changes. You mentioned non-communicable diseases, NCDs. What, in your reckoning, are the principal disease challenges today around the world?
Many of them are uncommunicable diseases. It's cancer, heart disease, diabetes. So it is overweight and obesity. These conditions actually are the key challenges also for our health systems. And I often say, just like we have through the notion of planetary boundaries to show there are limits to what our societies can cope with. We should start thinking about non-communicable diseases in a similar way, that we are crossing tipping points. If you have up to 60% of your population overweight and obese, health systems will no longer cope. Our societies can't cope because these people are not healthy enough to work regularly. They are dependent on social support and other things. So we have wonderful epidemiological graphs that show us all problems as they increase, and we don't know how to cope with them. But we haven't really discussed, is there a boundary? And we're already having experiences, healthcare financing, etc., that our healthcare systems are no longer able to cope. But politicians are not investing in health promotion and prevention, and they fear the political conflicts as they try to restrict unhealthy nutrition, as they regulate tobacco, alcohol, and sugary drinks. And there is a tremendous pressure in the commercial determinants of health. So we're not as healthy as we could be, as we should be. And I think that is a political scam.
Well, we are blaming everybody else, external factors, politicians, somebody not doing enough, private companies, businesses, commercial factors, and so on. But what about people themselves? What constrains them from making healthy choices?
In the Ottawa Charter, we identified 5 areas that interact to create health in everyday life. As you rightly say, people make choices. For some, it's easier than for others. And so it's very important to find the right balance between sufficient health literacy of people, but also the ability to make healthy choices. We see changes. For example, young people in our part of the world drink less alcohol than they used to, and the alcohol industry is complaining. The obesity discussions and the ability to deal with this partly with injections, we see that people are changing their food habits. And so a big food company has had to reorient itself totally because people are no longer buying unhealthy pizzas. So we see there is a dynamics in between people, what they are offered, and the policies try to ensure that the products which they get are healthy. And physicians should do much more than just treat people. There should be more social prescribing and a motivation for people to get active and take care of themselves and their families. Because the consequences isn't just me dying earlier or being ill. It's my whole family. It's my wife who has to take care of me. It's my children who might not have a father. And it's those things we have to take into account. But as a society, we do not really motivate people to be healthy. That is a problem.
It brings us also to this individual versus collective debate, doesn't it?
Yeah.
What to do with those who are unable or will not make healthy choices, even when it's within their control. And does the rest of society rescue them or not? However, let me move on to public health. It's a term we all use, but for our listeners, can you explain what trade offs are required between maximizing individual health and optimizing public health?
Well, public health is about the health of all of us. One can explain it best through water and sanitation. You know, could have in the 19th century told everybody when we started to understand the germ theory, cook your water. But the public health approach put pipes and sewage under the City of London to get started. Therefore, this is one example where you don't just always say the individual must, but where you create an infrastructure that makes it easier for people to live a healthy life. And that is the core principle of public health. What we also have to see is that if it's the health of all of us, it's something we have to do together.
Mm-hmm.
And that, of course, is the kind of thing during COVID-19. What do I do not only to protect myself, but also protect others. This approach to a whole population is sometimes not understood because if you argue for a tobacco policy, you will get people who tell you, my grandfather smoked and lived to be 96. That's individual health. And there will always be individuals who don't get ill. But if you look at the totality of us, we need an approach that keeps the highest number healthy. And for that, we have seatbelts, tobacco policies, vaccination. This is something we as a society shape together and where we support each other, which is why the state has to be active because it has tremendous consequences for our economic well-being, for our competitiveness as societies. And we see now in the discussions around democracy and populism that health is always centered there. How much does our society keep us healthy and what must be done to do that?
Which brings us nicely to the subject of global health, a fashionable term nowadays. I have it in my title and in yours as well. Is it just old wine in new bottles? Anyway, what is it?
Depends, as always, Mukesh, who you speak to. We moved from international health to global health at the turn of the century. It became clear that international implies it's only nation states that shape this arena, and particularly with Bill Gates entering the scene. But before that, Rockefeller and others, it was clear there were many new actors, organizations, social movements. The AIDS movement was critical and one of the largest. So we needed a different term, but also to express the incredibly complex dynamics of maintaining health in an era of globalization. How does health in one part of the world, which, the pandemic then showed us, influence another part of the world? How do we support others? When we introduced the term global health, we had a very dynamic understanding that was both political, geographical, disease traveling, structures, etc. But when Bill Gates came up, global health was more used about rich philanthropies or donor countries supporting poorer countries. And we have had many important civil society movements. Nearly every disease has a movement pushing for it to eradicate this, to address that. And so we're in a phase now revisiting this understanding of global health. The Global South itself says we don't want charity. We need different cooperation. And this is what we need to work towards in a very difficult situation where international solidarity is reduced, very much so, where equity is no longer popular, and where support of poorer countries is transactional. The new approach of the United States says, we will give you X to fight disease Y, and in return, you give us your health data. So it becomes much more interest-led.
So what happens to the MDGs, Millennium Development Goals, 8 goals, of which 3 were health-related, succeeded by the 17 Sustainable Development Goals to be achieved by 2030, of which we have one comprehensive health goal. Now, in such a diverse world and contentious, as you said, is it a good idea or a waste of time to prescribe goals from top high for all countries? In fact, we're doing pretty badly on the SDGs, aren't we?
Yes, we're definitely doing badly on the SDGs, though the Millennium Development Goals were a call to action, and particularly in health, that focus for that certain period of time worked. Millennium Development Goals were the last big effort of an international system that was already creaking. The goals were too simplistic. We focused on one issue and didn't look at all the other things around it. But it's not the fault of the goals. It's the fault of the political change, this commitment to creating a better world. That is not there to the extent it was. And The development goals were the last expression of a world trying to come together when already large divisions were happening. And we see it in health, you alluded to it. Actually, health has not advanced as much, and particularly the big goal to achieve universal health coverage is far behind. That is a real tragedy.
You're right, of course. And you referenced universal health coverage. Can you explain what it means and how far are we progressing?
Universal health coverage, as written in the SDGs, a relatively and straightforward concept. It's the idea that everybody, if they have a health problem, can access health services of sufficient quality, and that they will not fall into poverty if they go for treatment. The basic idea of universal health coverage, it was, developed together with the World Bank because of economic implications, not just of financing healthcare, but the positive economic implications for society if they treat their population and keep them healthy. The idea was to help countries build systems and to move away from financing one health program next to the other. Here's AIDS, here's TB, here's malaria, but actually to help and support countries to build health systems and start with primary healthcare services and a financing system that people, if they have to pay for medicines, treatment, will be able to do so. So it's not the idea, everything you want for free, which some people, imply when they're critical of UHC. Some countries, take Thailand with the 30 baht program, have established different types of insurance systems, of tax-based systems, etc., to enable people to do that. But for 20 years, we've put too much money into vertical programs instead of building systems where people get the help they need, both preventative and treatment-wise.
You emphasize systems a lot. And you can't open a health textbook without seeing the pyramid with primary healthcare at the bottom, then clinics and hospitals, and then super specialized hospitals at the top. We live in a very horizontal world nowadays. Isn't this ancient health pyramid too bureaucratic, almost Stalinist in the way that you're supposed to navigate it to get to what you need? Is it not time to bury this traditional health system or pyramid and allow people choice and freedom to access care as most convenient to them?
Yes, there are two sides to this. The pyramid was useful to answer the question, where do you invest first? And we had too many examples, in developing countries where tertiary healthcare systems were created because, that was attractive and money could be found for that, whereas the primary healthcare, the base, was neglected. And even societies that had that base have started to destroy it. Think of our societies where there's no more GPs, where, it gets really complicated. So that's one side. I agree with you. A pyramid can't work anymore. Digitalization, artificial intelligence, the fact that people can use and access information on health in totally new ways, and also culture. I get on the internet in a minute, I can order something online, totally different user-centered culture has developed, and the healthcare system hasn't changed. I still have to sit in a waiting room. Why can't I get some web-based service at your appointment 10, it's late, please come at 11. Even simple things like that don't work. And so we do have to revisit that. There is a financing element in our societies. I know in Germany and Switzerland, it's discussed a lot. Because of what you said right at the beginning about people now being worried that every little thing is something very, very serious, that they have a tendency not to go to their GP, but they go to the dermatologist straight away because it could be a cancer. And of course, medicine has contributed to that, sort of saying, oh, watch out. a little pain here and a little pimple there could be something really serious. I don't think we've resolved that problem. One of the reasons, of course, is money and overuse of parts of that pyramid. But also what the pyramid doesn't do, it doesn't allow for the dynamics of the different parts of the system working together. And again, that pyramid doesn't show. We have an aging society. The really important thing is the interface between the health system and the social system.
Mhm.
The transformation of the health system into something much more horizontal, much more easily accessible, much more digital and AI based is going to happen over the next 10 years. We will not recognize health systems in 10 years. And the patient and the user, the citizen, is going to play quite a different role there. Of course, many of the services themselves will be digital. Already now, much of the monitoring is out of date. You're totally correct.
I have this vision in my head of my medical professors in Oxford doing the ward rounds. My God, we were petrified of them. It seemed that the patients were there for the whatever of the professors and medics rather than the other way around. And this trend towards, you use the word user-centered or democratized approaches to healthcare, I think obviously that's the right thing to do. Brings us to money. Overall health spending worldwide exceeds $10 trillion annually. It represents about 8 to 10% of a global GDP of $117 trillion last year. Are there calculations on how much the world should spend on optimal health? And what should be the priorities for the maximum bang for the buck?
It's very, very difficult because GDPs, exchange rates, and everything changes. For our part of the world, there seems to be a balance somewhere between 10 and 12%, which is increasingly exceeded, moving up to 15% and more. It's a particular problem for tax-based systems because in the present geopolitical situation, the competition in taxation, how to use, that money is incredibly strong, particularly as countries build their military, but also in insurance-based system, the insurance rates go up and up. And it's a problem for people to finance their everyday life compared to their insurance rates. Now, what one doesn't do enough to those calculations, it's really add in the health industry, one of the largest industries of the world. And we see after COVID discussions about supply chains, pharmaceutical competition, eye health competition. It's an enormous private sector. And the interface between the public health spending, sometimes through, insurance and tax-based systems, is enormous. Individuals, families have to contribute, have to pay 20% of this and pay 50% of your medicines, etc. So if I take a country like Germany that was defined by car making, there are more people working in the German healthcare sector than the automobile industry, also because the automobile industry has gotten more and more automated. But on the other hand, what we need are humans that care. And part of that global health industry is actually people. So we are seeing an enormous competition for healthcare professionals. And that's an export-import business, not reflected in those figures. Countries have set goals. African countries have set the goal 15% of their GDP. And as I say, the OECD has guidelines somewhere around 12, 13%. Then we have the outliers like the United States and countries that have very privatized medicine, that there a very large chunk of the GDP is spent, but a lot of that is out of pocket by people themselves. So it's an enormous industry and where money is made, a lot of money.
Let me be specific.
Yep.
Let's imagine that Angela Merkel comes back as Chancellor of Germany and appoints you as her health minister. How would you finance the healthcare system of Europe's richest country, which is still Germany?
The basic financing would stay the same through social health insurance that Germany has. Principle 2 would be that it doesn't quite need as many insurances as Germany has. There is in Germany no significant investment in primary health care. A major part of the money goes into tertiary care, and that has to be revisited. And actually, Germany is going through a hospital reform right now because hospitals are too expensive and we have too many hospitals. That is one of the key problems if you were to compare it to Denmark, that had a very important reform in reducing the number of hospitals and also setting rules in terms of which kind of interventions can be done in which hospital, because you should only do interventions that you do a lot of so that they are of high quality and not that every hospital does everything. It's a question of what kinds of things are fully or partly reimbursed. Because over the last 50 years, healthcare systems have grown in such an abstruse manner without real planning. Actually, in Germany, as a health minister, there's only so much you can do, even if you put me there, because it's a decentralized, federalized system. And many of the decisions are taken in the Länder, and then you need all the Länder to come together to agree on something. And then whatever they've agreed on, reform, you have to agree with the central government. So the complexity of the healthcare systems makes it difficult to take decisions and so expensive in the long run. And then you have enormous power of the medical professions. You have the push of the insurance industry, and you have the enormous push by other industries, pharmaceutical diagnostics, increasingly the digital players, and they all have a profit-driven interest in that system. So we're entering a phase where we have to look at this in a totally different way and probably take some very tough decisions. The users, the clients, the patients will need to understand that there will be different forms of access. We all know that there's overuse. Look at the emergency services that are creaking and can't deal with the amount of people coming. And one of the reasons they come is because there is no primary healthcare they can go to, and it closes the door at 5 o'clock in the afternoon.
You know, talking about Germany just reminds me of the very first lecture I attended in public health given by the legendary Professor Brian Abel Smith at the London School of Hygiene. And he walks in and he wordlessly puts out a graph. And the graph showed the distribution of appendicectomies in German hospitals and how they were skewed between 9 and 5 on weekdays, and very few were done at weekends, even though, as you know, appendicitis is an emergency condition which can arise at any time, day and night, regardless of the day of the week. It was a profound demonstration of the medical choices and behaviors that physicians themselves make, which impact the bigger picture. But let's move on to more recent experiences around disease spread. We've had HIV, SARS, Ebola. What key lessons arise from global responses to such conditions, especially COVID, around which there has been so much debate? And have we learned from these pandemic experiences, and are we better prepared for the next one?
What have we learned? One thing we haven't learned is how important communities are. And we see even where countries have improved their preparedness plans, have improved their public health infrastructure, have improved the way they collect health data and all of that. So national preparedness plans have actually improved in many countries. Where we're less well prepared because of geopolitics is the supply chains, for example, and that is very worrisome. There is a lack of global solidarity now. Some of the global solidarity when, COVID started is not there anymore. And we can't actually guarantee, particularly with the United States having left the global community of WHO, how we will progress on data sharing. Will you get negative effects if you're open and honest and sharing? And we have examples where developing countries have been heavily hit because they said there's an outbreak here. So the pandemic treaty, again, we spoke about the SDGs being this expression we want to hold together. I think the pandemic treaty was also an expression of that. There was a political push from the global south to say, we need an agreement that ensures more equity in the next pandemic because of the drastic experience of not having had access to vaccines, etc. That is the tricky part that's still being negotiated. We mustn't forget a very important update of the international health regulations, a set of very pragmatic proposals of what countries need to do both within their country in terms of their infrastructures and systems and in terms of notification. So those things have improved. But because of the geopolitics, I would say we're not in better shape than 2019, 2020. In terms of willingness to cooperate, we're in a much worse state than we were during the pandemic.
I think that's a stark message. Brings me to global health security. Today, the word security is attached to everything. We have food security, water security, livelihood security, energy security, and so on. But the values of health, as you have elegantly described, are cooperation, humanitarian, whilst the word security evokes an aggressive mindset. And yet advocates wanting more investment in health using health security language. Should we not be uneasy with this implicit securitization of health in our extremely divided times?
It depends on context, because in Europe, we use the word security as social security and closely linked to public health. So the security word is not per se linked with the military. It is linked with a system that ensures that you're safe and secure within your society, that you're supported if things go wrong. Whereas in the United States, yes, the security term is not social, it's military security. Now, they are becoming more intertwined, I would say. Linking it to a nationalistic military type of security is not going to help us resolve the problems when you have a pandemic, because a pandemic will be global. And, as Tedros, the Director General, said, nobody's safe until everyone's safe. And that safety won't be guaranteed with military means. It will be ensured through solidarity, through working together, through knowledge, and through very strong public health structures and reliable supply chains.
Sticking with this gender security theme, WHO has been very active in health laws, the pandemic treaty and the international health regulations revisions. Very contentious. Do you think it's too much in a world where the international rule of law is already so much stressed in other areas? Can international lawyers really make the world healthier?
It's not international lawyers, it is member states. Of course, lawyers advise on, what can or cannot be in a treaty. It's really important political process where countries try through diplomacy and negotiation to reach agreement. And we have to defend major elements of the rules-based order, because we see what happens if power is only with the mighty. And in a dispersed world where, the hegemon has said goodbye to global health, the middle powers have to come together and seriously protect what we need to maintain. The World Health Organization sets norms and standards. What will we do if we have no more norms and standards for air pollution or food? We won't do the international classification of diseases anymore because some people don't believe in science. So I feel very strongly that an alliance of countries should stay together and protect that system and not get totally disoriented because the hegemon has decided to leave. We don't need a hegemon in global health.
WHO, it's a strong symbol of global health cooperation. And both you and I have worked in and around WHO. And are strong supporters, but also not backward in being critical. I think the criticism of WHO, the US has crystallized that. Use COVID as an example, but it goes beyond that. Is it justified or not justified?
I think some of the United States arguments are simply not true. But there is definitely the problem that WHO should have reformed its financing system much earlier. Now, when we say WHO, we also mean the totality of the member states and the leadership of the organization. Many people say WHO and they think of the director general as if he could run the show as he wants. He's got, 193, 94 member states who are not always acting very responsibly, I must say, and have it dependent on voluntary contributions. I'll give you something for this program, and I'll give you something for that program. I think the organization has probably gotten too wide in the areas that it deals with and became very top-heavy. People have rightly criticized that. The regional structure needs to be revisited, particularly also, the election of regional directors. We've had some unhappy examples recently. So there is a lot of pressure, but the willingness of member states to reform the agency is not strong. That's why I spoke of that coalition of middle powers. It says, come on, guys, we have to change this. And the US leaving was a wake-up call, even though they could have done a lot of that within the organization.
Which brings us to the wider global health architecture. And we are blessed with so many international health agencies. And here in Geneva, we have the Global Funds, HTB malaria, and the Gavi for vaccines, UNAIDS, and we have UNFPA, and there is UNICEF. World Bank does a lot in health. And then we have huge organizations like MSF, the Red Cross, Red Crescent system, and many, many health-related NGOs, some of which are billion-dollar sizes now. The critics say that the whole system has become too bloated. So tell me, is the global health system still fit for purpose? And how would you reform or improve it now?
No, I don't think it's fit for purpose. And we have too many organizations. We have very strange streams of financing. You don't know, also on what decisions are based. We see reducing development aid for health. We have many institutions that don't talk to one another. And we have very clear-cut competition between organizations. We have a drift within organizations that once you exist, you tend to do more and more. And I do think that as we need to think of, closing down some of these organizations, of merging in and focusing them, just like WHO has to focus. The Global Fund has been subject to mission creep as well. And there are organizations that were created in the 2000s that are no longer needed. But closing down something is more difficult than creating it. And for many individuals, it's quite brutal right now because, the money is not flowing. Many of the smaller NGOs have to close or let people go. The system is dysfunctional. There is no question, right down to the fact that in many cases, money calls the shots. And that means that certain individuals or organizations have more power than others and define what gets done and what doesn't get done.
Interesting. As we near the end of our conversation, I want to come back to you. Ilona, in all the time that I have known you and admired and respected you, the thing that has struck me most is your passion for inequalities. I think you burn with this mission to reduce health inequalities. It's a function, I think, of your upbringing and of where you were in Germany and India and so many things. So tell me, will the advancements in technology and ideological thinking about the way we organize the health pyramid in the future, will it reduce or increase inequalities between nations? Will these inequalities deepen or narrowed?
Well, the equation is very worrying right now because obviously this whole development of technology, AI, digital, etc., is in the hands of very few very rich companies and very, 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 very rich individuals. And already there is a big inequality in how systems are developed, who builds the infrastructure for a digitalized healthcare system in Africa. Again, we have geopolitics of, either China comes in and helps you build it, or the American tech giants come in and build it. And the question then is, who will have access and what do you pay with? One of the most valuable things in the world right now are data, and health data are particularly valuable. Therefore, we will see that countries, if they want support for their development, and this is also what is happening in the negotiations with the United States, will pay with their data. So there are new forms of inequality and extraction that are developing that are very worrisome indeed. I want to warn about these new inequalities because this needs significant investment. It also needs knowledge. We spoke earlier about accessing information on the web, but you need to be literate in different ways to differentiate misinformation, disinformation, or scientific information. So it's also becoming quite dangerous to get your health information from the web because there is no system that regulates and ensures health information integrity. So we are going to see totally new forms of health inequality emerging. Will we be able to use the tools that are available through artificial intelligence also for our population, or will they lag behind? These are the questions we have to ask as we have this transformation of our societies and health systems. The danger of an increase in inequality is very real.
Ilona, you had a truly fascinating career spanning decades that has seen many changes and challenges. But you have not just confronted, but used the turmoil to advance ideas of fundamental importance to humanity. And through it all, you have remained an honest critic. And I found this conversation, despite your stark messages, strangely optimistic because you remain inspirational. You haven't given up the struggle for health. Ilona Kickbusch, global health thinker, actor, critic, reformer, leader, thank you for being my most erudite guest on Trading Causes.